Is Julie Lawson, and I am the Executive Director of AVAHO. And I want to welcome you to another session in a series that has been a passion project for us here at AVAHO. This one is Quality Healthcare 2025 and Beyond, what the VA is doing specific to oncology patients now. We are in 2026, but we started this process in 2025. And so we want to go from where we were starting and move forward with this particular series to let you know what the VA is investing its time and energy into and how really it's special and different than community health care for our veterans. A quick disclaimer regarding this session. We had intended to bring in national experts originally, but they were unavailable to speak publicly about some of the items that we're going to cover. We want to assure everyone, all of our members and anyone else who's watching this, that everything we are sharing is public information. We are not sharing any inside information from the VA or from employees of the VA and its affiliates. And so anything that we talk about can be found really in the public domain by doing a simple search online or talking to someone who has information that is federally shared. So with that in mind, I'm going to get us started. I have introduced myself, but I'd like to introduce our guests today. We have Rusty Crawford and Janice Schwartz, and I will start with Janice Schwartz to introduce herself and what brings her to share her information and knowledge with us today.
Hi, so yes, I'm Janice Schwartz, and I am a past president of AVAHO, but I've been a member of AVAHO since 2014 when I joined the VA as an oncology nurse. I retired in 2024, so now I'm staff with AVAHO. But the reason I really want to get involved in this program is because I don't feel the public really understands the care that the VA provides, and I would like to get that message out.
Thank you. Welcome. And Rusty.
Hi, welcome everybody. My name is Rusty Crawford. I'm a retired oncology pharmacy specialist. I spent my entire 30 years at the VA working in oncology in Tucson, Arizona. Like Janice, I am a former AVAHO president and have been involved in many of the committees. I'm very passionate about this project because, as Janet alluded to, I think there's a lot of lack of information out there or misinformation about what the VA can do, is doing, and how it compares to community care, which is a hot topic right now. Besides a lot of patients in the public that might not be aware of this, I suspect there's a few of our lawmakers that aren't aware of all of this stuff as well. So hopefully we can get the right message out to everyone. Thank you for including me.
Thank you. And thank you both for giving time and thought to the answers that you have prepared for today, because as I said, we had anticipated some other folks being able to join us. And in lieu of them, it meant us going out and doing some heavy research. So I really appreciate the time that you both have invested in this. I'm going to start with a question that is probably my favorite that I'm going to ask today. And that is really what we believe differentiates the VA from community care in oncology care. And so for both of you, this is a question for both of you. What is it that makes the VA unique and special and really changes the experience for the veteran and their family?
Thank you. I'll go ahead and go first. My answers to this are going to be a little bit more generic about what differentiates the veteran and the VA patient. And I think Janice's answer is going to focus in a little bit more on the specifics of oncology care. So my answer to this is manyfold, but one, within the VA community, we see a commitment to serving our veterans that really doesn't exist in the private sector. In the private sector, you're just a number, you're just a patient. What do we see when we walk into the gate at the VA hospital? Abraham Lincoln's commitment to care for the veteran. What do we see when we drive into Banner Hospital? It's another Banner day. The focus is just not the same. And all of us that work inside that environment, I think we take that to heart. I also believe one of the things that is a very significant difference between the veteran patient and the community patients. One thing is their education level. Many of our veterans are high school graduates at best. So we have to tailor our training and our teaching and our education models so that they're appropriate for that particular patient. And within VA, I think we have more experience working with that patient population, and we can tailor our education and our training and the message we want the patients to get about their therapy in a much more understandable way. We also include their families a lot more, I believe, and other care support. Obviously, many of our veterans have a lower income level. What they live on is their retirement from their military service and their Social Security and those types of things. And this does impact people's ability to transfer and go other places for care, driving to care, gas costs these days, the time, all of those things. And VA, as Janice and I will talk about later, has really done some unique things to bridge these gaps. We know that we do have increased mental health issues compared to the community settings within our VA population. And what's important within VA cancer care is these mental health practitioners, providers, counselors are all involved in the patient's care as well. So they're not lost to that care. If they go out into the VA sector, they may be lost to some of those care and services if they're in the community. This is a huge problem right now. Many of our veterans, over 45%, live in rural communities, which is where they choose to live. And the Mission Act and the Choice Acts have certainly helped bridge those gaps. But as Janice will speak about in a little bit, the cost of this community care and the continuity provided by this community care do need to kind of be a little bit questioned. And it's still an issue because there's a lack of specialized care in these rural areas. So you can have the Mission Act and you can have the Choice Act, but if there's not an oncologist where you're living, then that's a problem. Also, one thing that is really critical, and we'll talk about this some more, is the impact on toxic exposures on certain malignancies. This is obviously different within our veteran population, and they're clearly understood within the VA system, you know, when you get your rating systems and all of those. So we know all of that information about our patients. In the community, they may not even know what branch of the service you were in or where you served or what you may have been exposed to. I believe that VA care also provides what I call a more one-stop shopping experience for the veteran because everything is under one roof. They're not running to the pharmacy. They're not running to the radiology department. They're not running to see primary care. It's all under one roof, and it's just a better experience and more cost-effective for the veteran. I believe communication is a problem between VA and community providers. So when we keep our patients at the VA, we have better communication between the oncology service and all of the veterans, other healthcare providers and support staff. And this really emphasizes the value and the significance of a functional electronic medical record that communicates between all care providers. And I do believe that within the VA, our patients may also have more access to clinical trials. The VA is one of the largest research entities in the country, and to have our patients get additional treatments and to learn from their cancer experiences benefits everybody in the long term. Janice?
So that was great, Rusty. I think you pointed out some really hot topics in the VA, and I think it really just boils down to some key differences between the VA and community care. Oncology in the community is different in many respects because the VA oncology care is integrated. The VA offers a centralized, veteran-centric model with an electronic health medical record that's accessible to all the providers at any VA. Coordinated care across all specialties, which is not unheard of in any other health system in our country. There's specialized expertise also. The VA oncologists have a deep experience treating conditions common among veterans, such as Agent Orange related cancers or military related exposures. And then there's the continuity of care, where veterans receive, just like Rusty spoke about, care from the same team throughout all their treatment trajectories for the long-term management of care. And then there's the cost control. The VA is generally more cost-effective for the government and the veterans, with fewer out-of-pocket expenses for the veteran. And then there's the quality and safety. The studies have shown that the VA often matches or exceeds private sector care in safety and effectiveness, especially in patient and outpatient settings. So when you compare that to the community oncology care, we're not saying that the care is worse. We're just saying that how it's provided is often fragmented. So yes, there's expanded access. Community care allows veterans to receive treatment closer to home, especially in those rural areas like Rusty talked about, where the wait time can be very long in some VAs. Then there's also that choice and flexibility where the veteran can choose which provider outside of the VA system they may want to see if there's not a specialist available in the VA. But that care coordination can be fragmented, especially if the records aren't seamlessly shared between the VA and the community providers. Now, some VAs are able to do that, but not all of them. So the records get sent and are scanned into the medical records, but they're not accessible live. And then the community care costs are much higher. They tend to be way more expensive due to the billing practices and the lack of centralized cost controls. So there's that mixed quality of care. While some community providers offer excellent care, quality can vary deeply depending on the location and the provider's network. So those community oncology practices, especially those owned by those private equity firms or large hospital systems, operate under a for-profit model. This introduces financial dynamics that can influence care decisions. When that revenue is tied to a treatment volume, many practices earn income from administering chemotherapy, imaging, and follow-up visits. A cured patient no longer requires these services, which can reduce that long-term revenue. And then there's the drug markup. Practices often profit from the difference between the cost of oncology drugs and the reimbursement rate. This can encourage the use of expensive therapies, even when the lower cost alternative may be equally effective. Without that centralized oversight, cured patients may be lost to follow-up and re-enter care only when complications arise, creating episodic, reactive care rather than proactive survivorship planning. The VA operates under a nonprofit, federally funded system with a mission to serve its veterans, not its shareholders. There's no financial penalty for cure. The VA benefits from curing its patients because it reduces those long-term costs and improves veteran health outcomes. There's no disincentive to eliminate disease. Veterans who complete treatment remain within the VA system, receiving coordinated follow-up, mental health support, and preventive care. And we have standardized protocols. Many VA clinicians are more likely to follow evidence-based guidelines without pressure to maximize billing. And as most people know, there's transparency and accountability, whereas the public institution does not always have that. As the VA is subject to oversight and performance metrics that prioritize quality over profit.
Thank you, both of you, for a very thorough answer and explanation. And I realize I'm the moderator, but I'm going to add something here just from experience, from having family members recently and ongoing for that matter in VA care. When you guys both talked about the availability of resources, kind of that one-stop shopping, the ability to spend time with the patient, perhaps more than you would in community care. Again, it's not that the care is better or worse anywhere. It's simply this is geared towards the veteran and their families. And having experienced it recently, I can say it made all the difference for the family. And so if you are a family member of someone seeking help for various health issues, but particularly in oncology, think about going to the VA for your cancer care. I can tell you personally, it makes a big difference having all of the resources right there at your fingertips, knowing that this system is geared towards the needs of your loved one and what they're going through and what they're going to need for the coming months and into the future, into survivorship. And so that's just to say thank you for everything both of you covered and to concur that as someone who has experienced it recently, it is absolutely true that the VA does a great job and really does make a difference for the families and for the veteran themselves. So with that in mind, Rusty, can you give us some examples of the care differences or specific health benefits within the veteran population in the VA, the ways that they may be different and maybe how outcomes may be different in the VA from community care?
Yeah, sure. Some of these have been historical, and they've been things that VA has been superior to other care models for years. Some of these are trends that are improving towards what the VA is doing. And I'm not going to give a lot of numbers. Numbers just make the water a little muddier. But in terms of non-cancer related benefits, heart failure management, 30-day outcomes from hospitalizations after discharge, depression screening, mental health screening, uh, preventative vaccinations, whether it's pneumococcal, influenza, shingles vaccines, all of those things, the VA historically has exceeded the private sector and still continues to exceed the private sector. In terms of some of the cancer specifics, there was a article published that looked at the surgical management of stage 2 and stage 3 colon cancers, which are ones that we go into hoping we can either cure or have a long durable remission. And there's a lot of data that shows racial disparities and economic disparities in who gets those adjuvant treatments after their surgical resection for colon cancer and who does not get them. And the numbers will show that within the VA population, there is no disparity between race, income level, where you live in offering and providing these adjuvant therapies. And then the offerings and the number of patients taking adjuvant therapy do exceed that which is offered in the community setting. In terms of patient satisfaction and scores and some of those things, these are important numbers because we've all been hearing that VA care and community care are interchangeable. And when you look at some of these numbers, it makes me ask, are they really interchangeable? So in CMS, that's Medicare, that's who pays the bills for everything. And so they looked at patient satisfaction scores in 2024, comparing VA to non-VA care. And if you look at the star rating, and a 5 is the best you could get, almost 80% of VA facilities received a 4 or a 5-star rating in terms of patient satisfaction. And that compares to only 40% of non-VA facilities receiving that same star rating of a 4 to 5. And in 2024, that did represent the 9th consecutive quarter that the VA had outperformed non-VA facilities in patient satisfaction scores. And I think globally what that tells us is we're doing a pretty darn good job of meeting the veterans' needs and understanding what their needs are. And those are two uniquely different things. Understanding what they are has to happen first before you can address fixing them. And so I think we know what is important to our patient population. We have staff that is well versed with working with this patient population, and it shows in the satisfaction scores. Also, and just recently, CMS put out their hospital quality scores. They had the same type of rating system. And almost again, 80% of VA hospitals received a 4 or 5-star rating. And these hospital quality scores are based on things like safety, medication, error prevention, infection risks, all of those things that are kind of inherent risks of being in the hospital. And the VA accounted for about 15% of all hospitals in the CMS survey that received a 5-star rating score. And that compares to 42% in the non-VA setting. So I do believe that these numbers show that we are providing both the quality of care that the veterans deserve and they're satisfied with the quality of care that they are receiving. Does it mean we can always do better? Absolutely. Absolutely. And I included this last little thing in here just because to me, it shows a little bit of mediocrity. In Arizona, they just put out a safety score study from this leapfrog group, and they assigned hospitals a B, C, D, or F grade based on the same types of things that CMS looked at. And if you look at the results, it's about a mixed bag between who got an A, who got a B, and who got a C. Luckily, nobody got a D or an F. But to me, again, it shows a little bit of mediocrity out there within the community hospital setting where nobody really seems to rise to the top as well as we are.
Absolutely. So that's a great insight into just generally speaking how the VA is doing a great job. But we focus on cancer care. So what are the differences between the VA and the private sector when it comes to specific cancers that are diagnosed or diagnosed younger? You mentioned earlier the burn pits, and so that's burn pit and toxic exposures. How is it different than what somebody might get in community care?
Well, I think we've got a long history of uh, toxic exposures, things that our service members have been exposed to over the years. And so we have a good understanding of their impact on patients' potential healthcare outcomes, both within oncology and outside of oncology. So yes, within the VA patient population, there are certainly some cancers that are far more prevalent per capita within the VA population than they are within the general community population. Some of the ones I'll focus on in particular, lung cancer, obviously. Um, our patients do have high and heavy smoking histories from their military and post-military exposure. Janice will highlight some of the things VA is doing to improve those lung cancer diagnostic numbers and outcomes. Prostate cancer, which we know is associated with Agent Orange, and head and neck cancers, which again are very more prevalent within our population because of smoking, drinking, those types of histories at some of our patients. So there are some cancers that are more common, and the things that we're hearing and we learned about over the last 30 years, Agent Orange obviously was the herbicide used in Vietnam, and as I will show on another slide, there's a lot of malignancies that have been, and this isn't the whole list, this is only some of them that have been associated with Agent Orange exposure. This is important for our patients because it affects their benefits. It affects their service connected rating, their income level. All of those things will be provided by knowing this history. And I have to ask the question, is the community provider even aware of these things if they're sitting down and talking to a patient? I will give a short example of my brother-in-law. When he was employed, he got diagnosed with diabetes. He was a veteran from Vietnam, but he did not use VA healthcare services. He had his own insurance and he went to the community. Long story short, after a couple of years, he lost his job. He lost his healthcare benefits. He lost all of his medication. So I told him to go to the VA, and they were close to losing their house at the same time because he was unemployed. So he goes to the VA. They do the full ratings, and he's deemed to be 100% service connected for his diabetes because of Agent Orange exposure. He gets a nice little check, and now he saves his house. The community provider didn't even know any of that stuff and didn't even address any of that stuff. And I have no doubt that if he would have stayed in the community, he probably would have lost his house and would not have had health care to treat all of these chronic issues. So, like I say, the Agent Orange was the first thing we kind of dealt with. Now we're hearing about Camp Lejeune water in North Carolina, and also the burn pits that were over in the Middle East that were basically our toxic waste dumps where we burned everything. And there's just a litany of malignancies that are all felt to be at least partially related to these toxic exposures. So this really differentiates what VA patients are compared to community patients because a lot of them never had these exposures and and they don't impact their finances.
Absolutely. And I think that's what I was alluding to also earlier. You gave the example of your brother-in-law, and that's what I was alluding to is not knowing that these resources are available that can be life-changing and can really truly make the difference between, as in your case, someone having a home and not having a home, based on what they have invested in their health care or the impact that their healthcare has had on their ability to work and to thrive. So with that in mind, because it is such a critical part of receiving proper care for the cancer, particularly with those wraparound services, question for Janice, how well do you think clinicians understand the differences that someone who's coming out of military service may be presenting with when they come into a diagnosis?
That is a problem. So, non-VA clinicians generally have a very limited understanding of what service connection is as it applies to a cancer diagnosis, because it's a VA specific legal benefits construct and not a medical one. VA can improve the way it educates veterans by standardizing the communication or embedding exposure related education into clinical workflows and strengthening the outreach at key points. However, that service connection, it's a legal administrative determination. It's not a clinical one. It's governed by VA regulations, which outline disease eligible for the presumptive service connection, which Rusty has previously talked about. And all those examples, again, the Agent Orange, the radiation, the burn pitch, Camp Lejeune, different particulate matter exposures are all things that can be considered when they're talking about this to meet this determination. Non-VA clinicians rarely receive any training on VA disability law. So presumptive conditions or the claims process that's involved with this. So community providers are expected to reference VA's clinical determination and indications when treating the veterans, but the CDIs focus on clinical appropriateness, not the legal framework of service connection. So even when community providers treat veterans under VA community care, they may not know which cancers are presumptively linked to service connection or how their documentation affects veterans benefits claims. But why really do you think this matters? If a clinician doesn't understand service connection, they may unintentionally miss opportunities to document exposures or onset of timeliness, or they may fail to connect a diagnosis such as a lung cancer in a Southwest Asian veteran to a presumptive exposure. This leaves the veterans unaware that they may be eligible for disability compensation, like Rusty and Julie have already talked about, or the priority enrollment or added benefits that they could receive. So it really does boil down to being a problem.
Absolutely. And so I really appreciate you covering that. And that's a gratitude to both of you for really giving it a thorough look at how this really does impact the end result for and the outcomes for the patient. And so my next question is, how do VA cancer screenings and prevention initiatives compare with those in private sector in terms of outcomes?
So the VA cancer screening programs, especially for lung cancer, demonstrate better early stage detection outcomes than the private sector systems, largely due to the VA's integrated structure, universal coverage, and coordinated screening workflows. Evidence shows VA outperforms Medicare, as Rusty has already spoke, along with private insurance and Medicaid, in shifting cancers to these earlier stage diagnoses. A large retrospective cohort study was done with about 1.5 million patients between 2006 and 2020, which compared stage at diagnosis across different insurance types. Findings were pretty significant. VA had the largest increase in stage 1 non-small cell lung cancer diagnosis after national screening guidelines were introduced. VA was at 12.74%, compared to Medicare at only being 2%, private insurances less than 0.5%, and Medicaid only at 2.5%, which is clearly a concern when you want to think about what we can do to save people. Because if all systems matched VA's stage distribution, 45,000 more patients nationwide would have been diagnosed at stage 1. And better yet, over 65,000 fewer at stage 4. So researchers attribute VA's superior performance to universal coverage, robust screening programs, and the integrated care coordination. VA's advantage is not just better screening, it's a better system. The integrated VA model allows consistent implementation of screening guidelines, whereas private sector outcomes depend heavily on insurance type, provider network, and patient continuity.
Thank you. And anecdotally, sometimes we speak more in terms of what the research is showing us, but anecdotally, what this means is, as many of you may know, veterans will go in for a normal, just, checkup for some reason. Maybe they're sitting in the waiting room and they're talking to someone else, and that person says, I got a prostate check, and I'm so glad that I did because they found this. So there's this encouragement not that is outside of even the purposeful effort that is word of mouth. And I think that's really important to highlight as well, that just culturally speaking, if you're within the VA healthcare system, you're exposed to other people saying, hey, you should probably go get this checked out or get this screening done. I did, and I'm glad that I did. So I think there's a lot to be said for the community that the VA bolsters in that way as well. In terms of, and this is a question for Janice, in terms of the structure that is lending its success to this process, what is the National Oncology Program and how does it benefit veterans with cancer? It's a unique model that the VA has, the National Oncology Program. So I'll let you describe that a little bit to those who are viewing this.
Sure. So the National Oncology Program Office is the United States Department of Veterans' comprehensive initiative to deliver high-quality cancer care to veterans. It's one of the largest integrated oncology systems in the country, diagnosing and treating over 56,000 veterans annually. Despite its many strengths, though, several challenges can limit the access or the effectiveness. Challenges such as awareness gaps, like Julie and Rusty have both stated, many veterans don't even know this exists or aren't aware of the full range of services that can be offered. Not all veterans qualify for VA care. Eligibility really depends on that service history, discharge status, and their income. The VA offers teleoncology, but it requires internet. So you have to have devices which can connect, which some veterans, especially older or rural ones, may lack. And then there's those conditions that we've talked about earlier that our VA providers are more in tune to. Conditions like PTSD or traumatic brain injuries can complicate cancer treatment and care coordination. And there's also that stigma or distrust that some veterans may hesitate to seek care in the VA due to past experiences or perceived quality issues. So barriers like transportation, health literacy, and mistrust can limit the participation in many research studies, which Rusty spoke earlier about as being a really great network for clinical trials. The VA does offer many benefits through the program office, such as precision oncology, using molecular profiling to match treatments to the individual patient, improving outcomes and reducing unnecessary side effects. They offer teleoncology services, which allows the offering of virtual cancer care through VA Connect or VA clinical telehealth systems, which expand access to specialists regarding of the location. And then they have the Integrated Clinical Trials Network, connects veterans to cutting-edge research and experimental treatments often unavailable elsewhere. They also have partnerships with other large systems, partnerships with the NCI and with the DoD, which enhance sharing and tumor sampling testing, especially for cancers linked to military exposures. And like we spoke about earlier, all the screening programs that are available to have the early detection helps us catch those early stages so that we can have better outcomes for our veterans. And then there's this extra support that is also included where we have veterans with cancer that are linked to military service can access disability benefits, specialized care, and giver support.
Thank you for that overview, Janice. And I will add, you mentioned that there may be a little bit of distrust sometimes. It could be the veteran themselves or a family member hears something on the news and they say, oh, no, we can't go into, it's not going to be as high quality. I want to remind folks of something, and that is that there are going to be medical errors in any medical facility because they're run by humans and humans error. But deeper into that point, the VA does not have a well-funded PR machine to go out and fix the message when something does go wrong, like a for-profit hospital, or not a for-profit, but a community hospital would. And so it's important to remember that there's machines behind messaging. And if there's not that machine behind the VA, you're not hearing all of these amazing things that the veterans have access to that match what you might hear in terms of a mistake made. And so, and we don't want our tax dollars going into a substantial PR fund, but that means that we're not always hearing every good story coming out of the VA. And so, speaking of money, how much, and this is a question for Janice, how much is spent on oncology care in the community versus what it might be spent in the VA? How might that differ?
So spending on oncology care in the community merely means that the care is provided outside the VA, but it's reimbursed by the VA. These costs have risen sharply in the recent years due to the Mission Act. Now, the numbers that we have here are old, but you'll definitely see an increase. So between 2017 and 2021, VA spending on community care, which includes oncology care, jumped from 10.1 billion to 21.8 billion, which is a 116% increase over that span of time. So exact figures for oncology alone aren't broken down so that we don't really have those figures to provide you. Oncology is one of the most expensive specialties, and its share in the community costs is substantial. So there's the growth drivers that we spoke about, the Mission Act, the PACT Act, which are broadening the eligibility for veterans to go into the community. And because of these increased referrals, which are due to either the geographic barriers, the wait times, or patient preferences. But the spending on care within the VA facilities only rose 32% over that same period, far less than what the community care increase was. VA care benefits from economies of scale, integrated systems, and nationally negotiated drug pricing. VA facilities often deliver equal or better outcomes, like Rusty spoke about the different articles that were quoted. And these compare to the private systems, especially for the chronic and complex conditions like cancer with integrated and centralized care. So typically community care is more expensive per person. It's due to that higher provider reimbursement rates, less centralized care coordination, drug pricing that is market driven, and additional administrative overhead. So veterans then can also face fragmented care, which leads to duplicating in tests, delayed communication, and less effective treatment plans. All these things tied together can make it difficult for the veteran to receive the better care which it could get if they remained in the VA system.
With that in mind, we're talking about the National Oncology Program, and they have been developing their own clinical pathways for treatment for various malignancies. And for anyone who's unfamiliar with that, what is the thought behind a clinical pathway? In fact, that sounds like such a technical term for those who might be laymen in this particular subject matter. And so, can you explain what the clinical pathways are, how they were developed, perhaps, and how they may differ than other care systems?
Sure. So the clinical pathways are evidence-based decision support tools that map out the most effective, safe, and cost-conscious treatments for the specific cancers. They serve as a standardized roadmap for clinicians, ensuring that veterans receive consistent, high-quality care regardless where they are treated. So the development process through the National Oncology Program Office was very rigorous. It included subject matter experts from all the different specialties, medical oncology, radiation oncology, surgical oncology, pathology, and pharmacy, all collaborate to design the pathways. The latest clinical research and treatment data are reviewed and identify best practices. All pathways are vetted and approved by the National Program Office within the VA. And then as new evidence emerges, pathway committees meet and discuss, and the pathways are revised to reflect those current standards of care. So people ask, why is there a benefit to having a pathway? Well, there's consistency when there's a pathway. There's efficacy when there's a pathway. There's equity when there's a pathway. There's cost control. There's care coordination. When I say consistency, we're talking about a reduced variability in the treatment that veterans receive across the country. And when we talk about efficiency, it streamlines that decision making for the providers. The equity allows all veterans receive that care based on the same high standards, regardless of what facility they are receiving that treatment in. And when we talk about the cost control, it's because it balances that clinical benefit with resource stewardship without compromising the quality of care provided. And because, like the many things we've said many times already today, the care coordination and being accessible to the electronic medical record. The pathways are built into that electronic medical record. So it fosters that multidisciplinary collaboration and communication, ensuring that all the care is well coordinated. So pathways focus on efficiency, toxicity, cost effectiveness versus the traditional guidelines that do not consider cost effectiveness and focus on efficiency and safety. And they are, like I said earlier, those pathways are integrated into our medical record so that they don't have to leave a record and go into another website to look at the different standard algorithms.
Great, thank you. Continuing with Janice, we've talked a little bit about what the National Oncology Program means, and again, how it might be different than what you find in community care. But one that may not be necessarily different, just unique within the VA, is precision medicine. And so what is precision medicine in oncology? What's the role of the National Oncology Program, and how does it benefit the veteran and frankly the provider as well? And then another question I have for that is, how common is it in the VA for people to receive precision medicine compared to the community care?
Great question. So precision medicine is really something that's becoming more and more popular within the VA system. Precision medicine in cancer care means tailoring the treatment to the individual characteristics of each patient's cancer, often using genomic or molecular profiling. Instead of a one-size-fits-all approach, it identifies specific mutations or biomarkers in a tumor to guide therapy decisions. And this is really becoming the standard practice within the VA. The VA has invested heavily in infrastructure, training, and technology to make precision oncology accessible system-wide. So precision medicine is transforming the cancer care that VA can provide. The National Oncology Program Office ensures the veterans receive personalized, high-quality, cost-effective treatment, often outperforming community care in coordination and outcomes. So an example of this would be a patient is identified to have an EGFR mutation. They might receive a targeted therapy rather than the standard chemotherapy, which offers that opportunity for higher response rates, fewer side effects, and better outcomes.
I think I'll add one comment to that from Janice. I think most of us believe our patient's best shot at having a meaningful response and good outcomes is their first shot. And by using precision medicine, you've ensured that you may be spending more money for your first shot, but it's money being spent the right way because the science says this is the best thing to do for that patient. So it really does give patients the most meaningful benefits with their first shot, because we may never get another shot again if they don't do well.
Agree.
Yeah, very good point. Yeah. So how has the national office made it easier to access oncological services within the VA, particularly in the rural community? It's been mentioned a couple of times that the VA plays an important role in access for those who live in rural America. How does the VA make that easier for them? And how has teleoncology played a role in that? And that's a question for Janice. Yeah, if you can go into that and explain that role of making it easier, making, the incorporation of teleoncology, and has it been successful?
Yeah, so this is one of the really exciting things that the National Oncology Program Office has dramatically done to improve cancer care through this National Tele-Oncology Initiative. In the US, there's about 66% of rural counties don't even have an oncologist. So veterans living in these areas often face long travel times or are referred outside the VA system. So centralized oncology hubs, like the Durham VA has, support spoke cities across the country, allowing the veteran to stay in the VA system through teleoncology. Veterans can meet with an oncologist from home or at a local VA facility via secure video platforms. And they can offer point of contact genetic counseling this way also. So it really, what it has done for the veteran is increased convenience, consistency, a comprehensive support team, and empowered them more. So there are able to avoid those long travel times and receive their care closer to home. Their care is standardized and they get to talk with experts in the field, even though they may not have access to anybody that way locally. And the visits can also provide education for the veterans. So since this teleoncology has developed, they can provide chemotherapy education, drug interaction reviews, and personalized guidance to the veteran also.
I think that is so critical for those who live in rural areas and maybe before would not have had the same successful outcomes because no one could reach them or they couldn't reach the services that they need. So thank you for explaining that. Can you share what has been accomplished to date in terms of the expansion of those locations and cancer services? Perhaps focusing on rural, but in general, how have they expanded from the major VA medical centers that we know of it throughout our states?
So a lot of the information that I found isn't current information, but it can show you the drastic expansion of what is happening with the teleoncology program. So 56% of veterans who received cancer care through the National Teleoncology in 2022 did live in the rural areas. And the National Oncology Program Office expanded from only having 14 sites to having 31 sites in 2022, which again is 116% of growth. The veterans themselves are reporting very high satisfaction and trust in this service, often choosing to remain within the VA system for their ongoing care.
Well, you've covered how the VA has expanded over time and continues to expand its reach into areas that may have been underrepresented before with oncology services. But what are some of the obstacles that were encountered in developing these new care sites? And how are staff trained to manage those issues?
So the development and implementation of a new VA teleoncology care, especially in those rural and underserved areas, does really have a lot of challenges when you first begin. But through strategic planning and robust training, the VA has built a scalable model that empowers staff and improves those outcomes. So the biggest thing when you think about teleoncology is understanding that many rural VA facilities lack that bandwidth or the hardware or the secure platforms needed for virtual oncology care. And upgrades were required to support high quality video consults, electronic health record integration, and remote diagnostics. So those local VA sites had often limited oncology expertise or staffing, and that recruiting and retaining specialists in remote areas was difficult, making that centralized support essential. So the teleoncology had to be woven into existing clinical workflows without disrupting any of that care. Then coordination between remote oncologists and on-staff site, those nurses, pharmacists, and lab techs required new protocols. So it was really something that was very phenomenal for the National Oncology Program to put together because of all these different barriers that were in place for them. And then veterans that were unfamiliar with virtual care needed support to feel comfortable using a video platform. And some of them had limited access to devices or internet at home, requiring creative solutions like the VA telehealth rooms. So when we talk about VA telehealth rooms, it meant that if a veteran did not have internet access at their home, they could go to a local CBOC and be placed in a private room and connect with a specialist from across the country in one of those rooms. So the staff had to be taught how to facilitate virtual visits, manage remote documentation, and troubleshoot all the kind of tech issues that come along with the internet. But out of this, so many different things evolved, such as the tumor boards. So we now have virtual tumor boards that allow local providers to observe, participate, or submit patients for multidisciplinary case reviews. And we also now have mentorship programs that pair rural clinicians with experienced oncologists from various hub sites. And then out of this also came the clinical pathways, which we spoke about earlier, that are embedded into the medical health record, which guide staff through that treatment planning by step by step.
So tell us what a virtual tumor board is. How do they benefit individual patients?
So sure. So a tumor board itself is just a meeting where oncologists, surgeons, radiation oncologists, pathologists, pharmacists, nurses, all the specialties involved with taking care of a patient get together and discuss a case. In a virtual format, these experts connect remotely, so allowing the experts participating from multiple VA sites across the country. And they review the imaging, the pathology, the genetic data, and the historical case history, and then collaborate and recommend the most effective personalized treatment plan for that veteran. So these virtual tumor boards are a powerful innovation in cancer care, especially within the VA system, that bring together a multidisciplinary team of cancer specialists to discuss the best treatment plan for that individual patient, all through secure video conferencing platforms. They ensure that every veteran, regardless of their location, receives a treatment plan crafted by a team of specialists tailored to their unique needs and grounded in the latest science.
And I think that's so critical because when we think about all of the ways that we complain about our technology and want to throw it out the window, it's really exciting to know that these are the ways that technology is really helping us to get all of those experts from across the country. We couldn't have done that 30, 40 years ago. And so it's really exciting to see this movement in using technology in ways that are really life-saving for the patient. Why do you believe a veteran might opt for cancer care in a community where care may be more fragmented?
That's always a question that we ask ourselves all the time, right? So there are probably several reasons why a veteran might choose cancer care in the community, even when it may be more fragmented compared to the VA system. While the community care can offer benefits like proximity or perceived speed, it often does lack, though, that integrated infrastructure of the VA. So, exploring both the concept of fragmentation and the motivations behind such decisions. A patient might see multiple specialists who don't communicate with each other, and medical records might not be shared across institutions, like we talked about earlier. And what I mean by that is that they are shared eventually, but not in real time, which causes a delay in communication. And the treatment plans may be inconsistent or they may be duplicated, and their follow-up care may be delayed or even poorly tracked. So this can lead to confusion, inefficiency, even medical errors, especially in those complex conditions like cancer. However, to a veteran living in a rural area, they still may think that getting their care closer to home and the community is better for them.
I want to switch to Rusty. We'll give Janice a moment to collect her thoughts again because she has given us so much wisdom and information. So we really appreciate that. Rusty, you were a oncology pharmacy specialist, and I think people have a misunderstanding about what a pharmacy well, a specialist or a pharmacist within the VA system does. We tend to think of pharmacists as the people who hand us our medicine at CVS or Walgreens or any of our pharmacies that we might go to, but I think it's very different in the VA. And so, can you explain what that is and what's their daily duties?
Yeah, I'd be glad to. Obviously, it's going to differ from institution to institution, VA to VA. So a lot of what I'll say is my own personal experience and the experience of my colleagues. But the oncology pharmacist is a highly utilized drug expert within the VA healthcare system whose services sometimes aren't even taken advantage of in the private sector. We've all made the comment we surround our patients with the whole team of people. So it's not just the pharmacist, but it's the nurse, the dietitian, the social worker, mental health, everybody that we surround. We've all heard stories. We have friends that go to community oncology centers. They have 20 minutes. They see the doctor. They see the nurse. They've never seen a pharmacist. They've never seen a dietitian. So the question is, who's providing the patient that medical education and their family that training so that it's at a level that's understandable? And that's a great role that both the chairside nurse and the oncology pharmacist can provide because they have the time to sit with the patient and answer all their questions And obviously, we have to make sure we're giving the right drug to the right patient. I mean, all of these things are basics of pharmacy practice, but most of us that are oncology pharmacy specialists, we rarely touch a drug. We touch the patient, we touch their family, we touch everyone that surrounds the patient, but we're not necessarily the guy who's counting, pouring, licking, and sticking like your traditional community pharmacists. We're the oncology drug experts. And the one thing that's important is that we don't make the decisions, but we're involved in the decision-making process. So there's pharmacists in the National Oncology Program that are involved in the development of the clinical pathways and in the National Tele-Oncology Program. So they're all out there just as another spoke in the hub that's out there providing that care to the patient. One of the programs I'd like to specifically focus on that's highly involved with the pharmacy program, and there's a funny story behind it, is the VA Close to Me program. What the VA Close to Me program is an attempt to take cancer care out to the CBOCs and the community clinics where patients might get their primary care, but then they had to travel into the mothership VA to get the more specialized care. The Close to Me program started in 2021 in the Minneapolis VA healthcare system. And the goal of it was to take the care to the patient instead of making the patient come to the care. And it gave patients the opportunity to remain within VHA if they did live in remote and rural areas. Between this and tele-oncology, there's not a patient in the country we can't reach and touch now, which 10 years ago was unheard of. So the Close to Me program, like I said, it started in 2021 with the goal to train the staff at all of these CBOCs and other facilities to have confidence and comfort in administering certain chemotherapeutic agents. I'd be lying if I said every chemotherapy agent known to man has rolled out into those, but the ones that require less aggressive hydration, less aggressive pre-treatment management, the ones that are better tolerated, lower side effect incidents, those are the ones that are being rolled out into the CBOCs. These are the numbers from 2025, and they're continually changing. We've treated over 4,200 patients through the Close to Me program at their home CBOCs with over 17,000 appointments. We've saved almost 1.5 million miles of gasoline and patient travel time at a cost of only one medical emergency that had a positive outcome. Adherence to the therapies is very high, almost 100%. And there was over $12 million, as Janice alluded to earlier, about how drug costs are different within the VA and the community sector. Medication cost avoidance in these 4,200 patients was over $12 million saved. So it's providing the care to the patient site, it's providing it safely. The nurses and the administration staff are being trained to be comfortable giving these drugs. And it's just one more thing that VA has done to accommodate the needs of the veteran patient. What are some of their future directions? Like I say, I think right now the Close to Me has gone to about 80 facilities so far. They're looking to get 25 new CBOCs up and running in 2026, and then expand some of the other options. Nurses going into the home for 5FU administration. A lot of the newer therapies are coming out in lower volume sub-Q pre-filled syringes where we can start learning how to teach patients how to do that for themselves. You know, you bring them into the CBOC, you teach, you observe, they display, and then they go home and they go do it themselves. So like I said, 10, 15 years ago, I laughed about this and said it would never happen. And now it brings nothing but joy to me that we can continue to reach out and take care of more of our patients instead of releasing them.
Absolutely. And I'm glad you said that because I think we all make that error thinking that something can't be possible, and yet technology and innovation proves it can be. And the VA has been really instrumental in that. I want to give them credit for some of the ways that I continue to hear that the VA is making a huge difference, and strides that in some ways are beyond even what community healthcare is doing. The the veteran experience in the VA is very different in terms of pharmacy benefits. It's very different working with a pharmacist from the VA than it is in community care. And I mentioned that earlier that it's not your average pharmacist. I had a meeting this morning with a member who is a pharmacist who was late, and he said, "Sorry, it took about 40 minutes with this patient." And all I could think was that there's no other world where that would happen, or they would spend 40 minutes, making sure that the patient really felt comfortable with the information, understood what was required of them. And I think that speaks very highly of what is different in the VA. And what I'd like to know, Rusty, is why is that important?
Well, I think it's important because it's an extra set of oversight. It's an extra set of ears. It's an extra mind that's listening to problems and trying to come up with solutions. I mean, we do consider ourselves the drug experts and we provide the counseling, but we're also kind of one of the first line people that patients go to when they have problems. As we all know, it's awful hard these days to get a hold of your doctor. Sometimes it takes days to get a message back from your doctor. Uh, I know my colleagues are no different than I was. I gave everyone my cell phone. They all had my office phone. And if there was problems, my expectation was you don't sit at home and ignore them. You pick up the phone and you call us. That's what we're here for. We're your first resource. And I go back to people that I know that get cancer care in the community. They've never even seen a pharmacist before. So if they're having a particular side effect or a particular problem, uh, there's just less people who have experience to sort through it all and maybe come up with a good answer and a good plan and an explanation. Um, I also believe that since most VA facilities are teaching hospitals, oftentimes the nurse and the oncology pharmacist have more experience administering and treating patients with some of these newer therapies than the people that are prescribing them. They're fellows, they're trainees. This is my first patient I've ever used this drug on. And then they'll come to a Rusty and come to a Janice and say, please share your experiences with me so that I can learn from you on how to take care of my first patient with this thing. So, the pharmacist is and the chairside nurse, they're integral in the patient's care and integral in making sure that good things happen, that there's a monitoring plan in place that is appropriate so that patients don't get lost in the crack. So, I consider us kind of jack of all trades that are really just there to advocate for the patient's best outcome.
Absolutely. And I think this ties into that there's not as many doctors as there are other people who can help with these things. And so that's what's very unique, I think, also about the model is you can take the time sometimes with a patient that someone else may not have because of their clinical duties. And so it's been amazing from the outside in, from someone who has not been a VA employee, to see how those systems work together and how you do pull from patient care and say, well, this person's busy, but I'm going to sit down and help you with this and help you understand what's going on and what's happening in your body and how you're responding to your treatment. And I think that's critical for veterans and for the family members to understand as well. And so
And
is there,
I'll give one more example, and
yeah,
it's not even involving the pharmacy, but all of our oncology clinics have a dedicated dietitian assigned to it too. So you have patients that have certain malignancies where they have nutritional deficiencies, eating deficiencies, they're on tube feeds. And if you're at that community office with the nurse and the oncologist, who's going to give you guidance and advice on nutrition, and who's going to write you an order for your nutritional supplement? They're just going to turn around and send you right back to the nutritionist at the VA anyway. So you may as well be there in the first place.
very true, very true. So Rusty, is there a process for VA oncology pharmacists to evaluate community provider requested prescriptions? So I'm in community care, somebody gives me a prescription. How do I get it filled? And is there communication between those two entities? And how would that maybe be valuable for the veteran?
Yeah, there is a process. All community prescriptions, whether it's oncology or any other community care that is being provided to a patient, they are evaluated and reviewed by a VA pharmacist before they're dispensed to the patient. Orders for oncology treatment are generally reviewed by the oncology pharmacy specialist who covers that VA facility. I think this review process is important to the veteran because it ensures that what the community provider is prescribing is both safe and appropriate for that given patient at that time in their treatment history. It ensures that their labs are within normal. It ensures that there's a monitoring plan in place. And to be honest, it ensures that they haven't already had that medication before. The community providers do have access to the patient's medical record, and the community providers do have the ability to electronically transmit the prescriptions to the VA facilities, but they are still all completely and fully reviewed to make sure that they're safe, appropriate, adhere to the pathways, and that it's the best thing to do for the patient.
Absolutely. I think that's the bottom line is what is best for the patient that the VA is really dedicated to. So to round this out and to close out all of this amazing information that you both have shared, I have a question. We'll start with Rusty, but Janice, please feel free to add in any thoughts. What would you like the average American to know about oncology care in the VA?
What I'd like the average American to know about oncology VA care is that one, every medication that is available in the community is available at the VA if it's the right thing to do for that patient. People think, historically, people think the VA goes for the cheaper drugs, the generic drugs, as Janice has alluded to with precision oncology and all of that. That's not the case anymore. The case is do the best thing, do the right thing, do it sooner instead of later. So every medication is available. If it's the right thing to do, you will get that medication. I'd also like the average American to know that VA has higher usage rates of precision oncology, genomic testing than in the community setting, which does ensure your treatment plan is personalized for you as the individual patient based on your own unique cancer characteristics. And this thereby will increase your chances of a successful cancer treatment outcome. In the community, you see the doctor and the nurse. That's it, usually. At the VA, you can see all of those providers plus everybody else that is part of your care network. If you need to go see your mental health provider after your treatment, that's available. So it puts a far bigger umbrella of safety around our patients than a stop and shop community setting. VA offers, as Janice alluded to, the things such as teleoncology and virtual tumor boards at a far higher rate than the community to assist in ensuring treatment is patient-centered and that no patient gets left behind, no matter where they live, no matter what their income level. And I provided some of the CMS scoring and data that shows whether you believe everything Janice and I say or not, the numbers don't lie. The VA outperforms the private sector hospitals in terms of both patient satisfaction scores and their Medicare safety grading scores.
I think the only thing that I would add to that very comprehensive response, Rusty, is that sometimes veterans think that they need to see a specialist and they want to go to the university, and they don't realize that that same doctor usually is the same doctor that they see in the VA, because many of the oncologists in the VA system also work within the university hospitals also. They're dual appointed. And so although they think they are getting the specialist, it's the same person. And at a higher out-of-pocket expense for them at times, based on some of the different things that are included in their care, which don't always get communicated to the VA. So if a patient is getting care at an outside facility and they get referred without getting that care approved, that veteran can get stuck with that care, which is another problem that we see with community care right now. So again, it all boils down to that lack of communication that goes between and the veterans don't always know. Veterans are veterans. They do what they're told. So if their veteran says you're going to go out and you're going to get surgery with my dog, with my colleague, he's going to go there and get surgery with that colleague and doesn't even know that it should have been authorized first.
Thank you for that. And thank you both for a very comprehensive overview of really what is the critical difference of being in the VA in terms of the patient experience, the experience for the family members of the patient, and what they're going to need now and into the future of their care. I will just close it out by saying there is a difference between VA care and community care, and that difference matters. Thank you very much.
Thank you for allowing us this opportunity.
Yes, thank you very much.